today's program titled Predictions about Predictive Analytics from Telescope to Microscope, sponsored by AIS Health. At this time, all participants are in a listen-only mode. And later we will conduct a live question and answer session, and if you wish to ask a question live, you must be listening to this webinar on the telephone at that time. For those of you who are logged into the web presentation, you are encouraged to submit questions throughout the conference by selecting the chat pod located in the lower left corner of your screen, and type and send your question that way. If you choose to listen to the webinar over the telephone, please don't forget to turn off your computer speakers. And look at the top left-hand column and click the speaker icon to turn the computer speakers on and off. If you choose to listen to the conference through your computer speakers and you experience any problems with the internet sound quality, please dial back in on your telephone. Now I'd like to introduce our host for today's call, Jill Brown. Jill, you may begin.
Thanks, Wendy, and welcome to the live webinar, Predictions about Predictive Analytics from Telescope to Microscope, which is hosted by 3M Health Information Systems. I'm Jill Brown, Executive Editor of AIS Health, and I'll serve as the moderator for our discussion today. In this hour-long program, Herb Fillmore, the Senior Director of Population Health and Strategic Innovation at 3M, will discuss how payers and providers are shifting to a microscope approach to actionable predictive analytics. It's one that takes a detailed look at the individual patterns that make up patient behavior and allows for identification of where real change can occur, rather than a telescope approach that focuses on gathering a universe of data. Herb has over 30 years of experience developing, delivering, and evaluating innovative healthcare solutions for all populations. He's led major statewide and regional healthcare financial transformation efforts, implemented new models of community-based long-term care, and directed the startup and operations of a special needs managed care plan. After our speaker presentations, we'll open it up to your questions. You can ask a question using the web platform by entering a question in the chat pod at the lower left corner of your screen. To begin our webinar, here is Herb.
Good afternoon. Thank you for joining the webinar. I saw the list of individuals who have signed up for the webinar. It's quite an impressive group. I would have really liked to meet all of you, but we all lead our busy lives and can't all get together in the same place. I hope today to provide you with some interesting information about the work we have been doing over the past 5 or 6 years, really focusing on predictive analytics to help our customers throughout the United States, both payers and providers, be able to identify opportunities in their systems and with their patients to improve care and lower costs. And during that time, we've had some successes. We've actually gone down some rabbit holes. We've learned quite a bit, and we have a very rich backlog agenda of items that we want to get to. Our customers inform what is next and what works with what we've done to this point, as well as the literature and the marketplace. But I would have to say that our customers and their successes have been most important in helping us sort through all of the opportunities. As I looked over the list of people that signed up for the webinar, I see that a lot of you are either delivering care, managing care, or some of you are also designing the kinds of analytics that I'll be talking about today. And I welcome your participation and conversations after this webinar about questions and items that you're dealing with. I think that we all share in this effort to try and improve healthcare. And I'm very much a person who believes that obviously each of us has to put bread on the table, so we protect certain intellectual property. But overall, the work that we're doing, the problems that we're dealing with, really benefit from more rather than less dialogue. So I hope that I can contribute to that dialogue today and that this is valuable for you. I'm going to be talking a little bit about my bona fides. I began my career actually in predictive analytics back in the 80s. working on base expectancy rates for various outcomes, and during different periods of my life when I've been involved in various activities, whether it's healthcare finance, healthcare quality, managing healthcare institutions and systems. I've either used or been involved in developing predictive analytics in the last 5 or 6 years, about 6 years now, since I've been with and around the 3M HIS group. I've been leading a group of individuals working on developing, deploying, and evaluating predictive analytics. And we're going to talk about some of those experiences. I've rolled up my hands, my sleeves have gotten dirty. I have to say that a lot of credit goes to the data scientists and others that I work with who are really so far advanced in terms of the techniques that are out there right now, and the ability to bring a level of science that just wasn't available 30 years ago. So it's a very exciting time. Big data brings a lot of opportunities, and a lot of the new scientific approaches bring a lot of opportunities. That's also true that it's very important to how you set up a problem, how you think about it. These are things where the art and the experience of working in the real world combined with these scientific methods can really help us. And having a feedback loop when you put these analytics into the environment is really critical. I just don't see a lot of value in publishing large models that people take off the shelf and use without calibrating them within their own environment, and there's no feedback to the developer to improve those and make sure that they really have the right kind of accuracy and utility in the environment. So I'm going to talk a little bit about that philosophy, about the foundation for our work, about our approach, what we think the future holds, the near-term future. Obviously, the future holds a lot, but the near term, I think we can see where that might be going, and then some current examples of what we're doing. Not a lot of time to do that, but we'll touch on each of those areas. So, first of all, our approach is, why are we doing all this? Well, we think that medicine is doing a good job and is always improving around how we deal with individual patients and their diseases, right? But changing systems of care is still something so that physicians and nurses and all the rest of providers and caregivers and individuals who are trying to manage their own care, creating the systems that support those activities is still, I think in some ways, a more complex problem than even treating some of the diseases. Obviously, we have a long way to go with disease treatment, but I think we, in some ways, have a longer way to go in terms of the way we organize the systems of care and supports for delivery. And I think that what we're trying to do with predictive analytics is really support information which will help people target the programs that they design, the way they organize their systems, as well as what they might do or offer to individuals. It's very important, especially for individuals that a lot of us are focused on now, those with multimorbid conditions, that we can begin to identify what's the priority here and what's the best approach. And many times when you're looking at individuals with multimorbid conditions, there isn't just one approach. There isn't just one issue, obviously. And so identifying what the priority is and what the probabilities are and the opportunities here and what pathways are best is really what we're trying to do now, and I think we're going to do better in the future. So we want to help as people change in their health status and try to manage that. We want to help them respond to these challenges. Now, just a little bit about philosophy. Another piece is that, so the first piece was systems and thinking about systems and not just thinking about the individual patient and their disease. We believe that It's very important to take a population health approach to predictive analytics as well as a lot of our other work. And what does that mean? Well, that means identifying cohorts of individual, and really I should use the word population health management. Identifying cohorts of individuals who have similar characteristics that we want to design programs for and evaluate the performance of those programs. And part of that means that we change the way our systems are organized. And here's just an example of, there's been a lot of research which is showing us that the items that we're concerned about, whether it's readmissions or use of low-value services or potentially preventable emergency room visits, any ambulatory care sensitive admissions, these types of things are best approached in resolving those issues, are best approached from a systems perspective, and looking at not only what's going on with the patient, but looking at the large system. So when we think about large systems, we think about multiple determinants of health, of social determinants, those kinds of things. But then in the middle of that is the provider system. And that can be macro or micro, that can be a group practice, that can be a hospital, an ACO. So if you think about this as three levels, you think about the patient, the provider, and the larger environmental system around them. Those of you with a public health background will immediately recognize the old public health model for looking at public health and understanding the interventions. That's the approach we take here. And we think that with that kind of approach to predictive analytics, you will deliver a product and tool for identifying what's going to happen next, and even perhaps what is the best approach to what's going to happen next. That's going to be much more precise. And we found that to be true. For example, we build readmission models. We don't just look at the condition of the patient, either now or for the last 12 months. We look at their interaction with the healthcare system. So we move up that level, those three levels. We look at their social circumstances. Where do they come from? And get as much information about that patient's environment as we can. And if you factor all of that into a model, it can help you much better explain what is going to happen with that patient. And the statistics, the performance statistics, are much better when you incorporate all those elements into the model. Obviously, you need to have the data to do that, and that's really a foundational piece of what has to happen before we do anything. So this slide that's on the screen right now just reinforces what I was saying, that community demographics are a key part of this. So let me talk about this foundation, what you need in order to do this. We think that you can't spend too much time on the foundation upon which you build your predictive analytics tool. And that's getting your data right, getting as much data as possible, but also cleaning it, enriching it. Clinical and claims data is very important. Clinical data is really great. As I mentioned, I started out my professional career building base expectancy. Base expectancy means that everybody on this phone, if we're talking about readmissions, regardless of what you get admitted if you ever get admitted to the hospital, you carry with you a base expectancy for readmission. In fact, you're walking around right now with a base expectancy for a hospitalization, and that changes over time. And so claims data really helps us with those base expectancies. Clinical data, better known as some electronic medical records data, but can come from other sources as well, will tell us more about what's happening right here in this moment. Now, what's interesting, depending on what you're trying to predict, don't disregard claims data. because I've seen some situations where you're trying to predict certain types of outcomes, and the base expectancy rate can really dominate the information that's important to understanding that outcome. The clinical data adds something. It certainly always adds something. But sometimes if you don't have it, it doesn't mean that you can't act and you don't have good information. In fact, most of the information that you need can come from claims data or longitudinal administrative data is another way to think about that. So, the effort to clean that out, to put in place the right business rules, to test for completeness and all the rest of that, that has to be done in order to get good data. Sounds like, well, everybody knows that. Or, yeah, I know, but so often there isn't enough data driving the development of these models, and the data isn't, not only is there not enough observations, it's not wide enough and it's not deep enough. And I strongly recommend that that be something that you pay a lot of attention to as you either choose models, what is the basis for all this work, and or if you're developing models, that this just can't emphasize this enough. The other thing is, what do we want to predict? So you can predict just about anything, and as I mentioned, my presentation today is not around predicting specific disease states. Okay, there's plenty of models for that. What I'm talking about is fairly important, not that disease states aren't important or change in disease, and we will come to that, but talking about things like readmissions, preventable ER visits, ambulatory care sensitive condition admissions, the use of low-value services, continuing high need, emerging high need. So these are states or events which exist. They aren't identified as being attached to a particular disease. And we chose to focus on those kinds of things because those are the kinds of things which systems are not getting right now and which you need a system response to deal with. And in an environment in which we're asking systems to change and perform differently, we needed to choose the right measures to help systems reduce total cost of care while improving the quality of care. So we can provide more insights than what providers can get from looking at patient by patient by patient. We can roll that up and give them an idea about where they need to go with their population. So the way we approach our work, as I mentioned, is that we talk with our customers about the populations that are most concerned to them, and then we respond with models which reflect the programs that they have, the kinds of environments in which they're working, and try and introduce these models into their workflow, their environment, so that it fits where they're at. Again, I think if there's nothing wrong with large models that are simply published in the literature and we try and replicate. All of us learn from those. But I also think that if you try and make one size fit all, that the model may end up not really speaking to the local environment, may not be believed, and it might in fact be inaccurate. So it's very important, I think, to have the core attributes of the model, but it's important also if there are opportunities to add in variance and to, most importantly, to calibrate the model to the local environment so that the accuracy that you published on your general model development is either replicated or improved in the local environment. So that simply means if your positive predictive value let's say for predicting a super user or a high-need individual, is 70%. 70% of the time you're right. You should really check that in the environment in which you're applying that model to make sure that it's really working there. So one of the things, here's an example of some of the work that we're doing and where we think things are going and what we've been learning is we've tried to integrate one of the hot topics now, of course, is social determinants. We like to think of talking about multiple determinants before we talk about social determinants because people use the phrase social determinants to mean so many things, and we find it can be a little confusing. So we like to talk about multiple determinants, and we're not unique in this. A number of people have broken the world up this way. So first we think about the physical and behavioral diagnoses. The ICD-10 does a good job, gives you that information. We talk about functional status. So those two things are fairly well known, fairly well codified. And when we use unstructured data mining also to gather information, that information can be reframed into these existing code sets. And that information is already being used to drive some of our models. So those first two columns, physical, behavioral, and functional status, are very important. We've done quite a bit of work. Certainly on the first one, the physical and behavioral, and looking at profiles there. And then on the functional status, what we're finding is that that is very important, again, for the population I was talking about, multi-morbid and individuals who are frail. I don't think you can have a fully accurate model without including this information, but you don't have to include it all. And we've done a lot of work to show that not all of the ADLs or the IADLs are all that important for understanding what's going to happen next with this individual. Okay, they're important for care, don't get me wrong, but when you're trying to build a prediction model, what's important for bringing into that model that will change your understanding about what's going to happen for this person in the future. There's a limited set of these that are important, okay? And they interact with the physical and behavioral diagnoses. And then the third column there, readiness and ability to change and manage, all this comes out of that health behavior literature that I think most of you are familiar with. And it's so important around patient activation, readiness for change. We know about motivational interviewing. We know about the ability to understand what's happening and the willingness to do that and having the personal tools to do that. And frankly, having the experience with your care provider that allows you to take action. And one of the things that we found, and I think a lot of people believe this, and I don't think this is a completely unique finding. But when I share it with people, they say, "I'm glad to hear that. Have you, can you prove this?" And the answer is yes. So what am I talking about? One of the most important things that we found in this realm of readiness and ability to change and manage that predicts what is going to happen with that individual is an answer to a very simple question. And that question is, are you confident that you can manage your health? Okay? So if the person is not confident, there may be many, many reasons. It may be because of their own internal processes, or it may be because of their relationship with their provider or lack thereof, communication issues, all kinds of things, polypharmacy, you can name it. But it is a screening question which opens up an incredible amount of information to the care provider and frankly supports your predictive modeling. So, and the beautiful thing about that, by the way, is that many of these predictive models depend upon vast amounts of information, right? One of the questions we always get asked is, these are great, but I've got new people walking in my door every day. How do I understand where they might be tomorrow? Now, I can ask them a whole lot of questions, and then we may have recall bias, we may have all kinds of issues, but how do I find out something today that's going to help me know about tomorrow? So my recommendation to you is that if you do nothing else, that asking that question and incorporating that information into the care processes of where you work or the people that you work for can be very powerful. So that's just one example of that kind of information. It's important. And finally, we get to the physical and social environment, and that's what a lot of people are talking about when they're talking about social determinants. And there, what we've been doing is we've been using both local information that comes in from HRA, health risk assessments of various kinds, or we use public data sets and we incorporate those in a ecological modeling fashion into our predictive models. So all of these are really important. And do we always have all of this information? No. Frankly, these days, we pretty much always have the first one and the last one because, again, we have everyone has access to these large public data sets. In the middle, many times we will have functional status more and more and more, depending on who we're working with. When we work with Medicaid, lots of times we're going to have it. Even in the commercial populations, we're starting to get it. The readiness and ability to change manage depends on the HRA tool. We have a state where we get this on every Medicaid client. And in other places, it's more isolated. But what we're doing is trying to build out and impress upon our clients the need to have this information to improve accuracy. So we see an evolution here in modeling. We see, the old approach was, first we have health status, we look at utilization and mass risk. We started adding in the system factors, and now down at the bottom we're adding in all the things I talked about and this idea of personal value. Personal value, we're not quite there, but that is very important. That is the idea really coming out of personalized medicine, also coming out of some of Porter's work at Harvard around the value equation, and the ability to understand what is important to the patient. And I can't tell you that we always know that right now. And I think we're putting a lot of work into trying to determine how do we get that information, how is it codified. So part of what today's presentation was to be is not just talking about what we're doing, but talking about where we think things are going. And I think if you're going to deliver information to a provider and to a patient, these predictive tools should be used to help patients make decisions as well. What are the probabilities that if I make this choice, if I do take upon myself the kinds of lifestyle changes that I need to take, what are the probabilities of success here? By the way, you're probably back one sign. You're probably saying, "Well, Herb, where's the genotype?" Yeah, you're absolutely right. So that factors in here. That gets plugged into the next level, and that may actually come even faster than personal value. But I'd like to stay with that idea here in a minute. So genotype is all part of this too. I have to say right now, honestly, we're not working with that right now. We have more than enough to deal with. We have more than enough value to bring to our customers with all of the items that I've been talking about. And frankly, these models, it's been my experience. I would love it if we could all be in the same room. I'd like to know your experience. My experience has been that care delivery is when you really can give somebody an actionable predictive analytics model, a lot has to happen in order for people to use that information effectively. And I think care delivery is catching up. We're catching up, but this, so people are like, well, where's the genotype? Where's all that other information? Let's make progress with what we've got. Let's do all of the incredibly valuable things that we can do now, and then bring that information in as well. Because frankly, genotype will just be one more factor. It is not going to be the factor. And everything that we've been talking about, we don't know yet what the percentage is going to be in terms of what influences. We've all seen that pie, what influences health. And I think in that pie, what is it, 25, 30% of health is, and maybe less, is influenced by healthcare. And then there's all these other factors. And so we're going to sort all that out over the next 2 or 3 decades about how all this interacts with each other. Right now, we got plenty to work with so that we can understand where patients are at today, look at the individual patient, gather this information in terms of where they're at, what's important to them, and then build that up into populations so you can begin to deal with what a population needs in an effective way. So, and part of understanding that patient is the individual's personal value equation, and simply that means what will it take for them to take that step and what's important to them. So I think that the next frontier will be when we deliver a series of options so that each of us, faced with a series of choices, can look at something fairly accurate about what for us, people like me, what if I choose to go this way or I choose to go that way, what will be the outcome? And given that I value this outcome over that outcome, what is the right trade-off between cost and benefit? So, but we've got to do some building blocks first. So what have we been up to? So we do a lot of work with categorical taxonomies of patients and their interactions with the healthcare system, the severity of their health status, and we can identify many, many different constellations of individuals who are like in their health status. And that likeness is also associated with outcomes for those individuals in the future. And so that's the clinical risk groups, and we use those. You may or may not have heard of them. Sometimes they're called CRGs. There are other models out there. HCCs are a different kind of model. They give you a number. We give you a group, and we say this is who this group is. This is a group of persons with diabetes and other morbid dominant chronic conditions. Here's a group of individuals who have catastrophic conditions, that kind of thing. Then we look at individuals who have gaps in care. So these are models that we have out there that are being deployed now. And the gaps in care model looks at individuals who should be receiving care but have not been. We have potentially preventable readmissions and complications, potentially preventable emergency room visits. So we have models for predicting who's most likely to be at risk for those kinds of things. And then we have what I'm going to talk about here shortly is a persistent and emerging high needs. And use those examples because I know that that's of concern for a lot of individuals. Who really is going to be that person who's going to have continuing need in my system? So the persistent high needs model says it starts with the setup. Remember how I said we've got all kinds of really advanced techniques now for structured and unstructured modeling. Well, let me say that differently. For pulling in unstructured data, structuring it, and then doing modeling around structured data. I think that's the most accurate way to say that. We know through the CRGs and other methods how to identify individuals who, say, for example, have malignancies or who have catastrophic conditions for which there are things that we can do, but we know who those individuals are, and we have a set of processes for taking care of those individuals. And yes, can we influence the trajectory there? Somewhat. But it's a fairly known and fairly consistent environment in which we're working in a set of conditions. But there's a group of individuals that are very difficult to identify and work with, who aren't identified as being catastrophic or malignancy. And just to say, well, okay, give me all the multimorbid people that I have. Well, when you do that, you're going to end up with a whole lot of people to work with. And not all of those people need to be worked with. Many of them may be stable. Their meds may be under control. They may have great relationships with their primary care and specialist physicians. Everything is okay. So having those in your model is not all that useful. So we need something that will be more precise. And so we've been asked over the years to help identify who are these other people who are super users that we can do something about, that we need to identify early and be able to intervene with. So we've spent a lot of time working on that, and one of the first things we did is when we were asked to build one of these models by starting with the idea of looking at the individuals who were most high cost last year. And they said, okay, we want you to identify the super users. And we want to make sure that we get all the people that were high cost last year. Well, it's a great idea, but it's not a very good idea. And you know, let me say it's not a great idea, but it's an obvious idea, but it's not a very good idea because of this concept of regression to the mean. So we demonstrated this to the customer, and I've done this in dozens, literally dozens of data sets with many millions of members in those data sets. What happens if you take, say, 1,000 people that were high cost last year? What happens is that if you plot that cohort over time and you say, what's going to happen to that cohort over time? What happens is that as you go through time, every month, some of those people are no longer high cost. And you can look at your own data sets. You'll see this. It's regression to the mean until you get to a certain point, and then it flattens out. And you'll see this in your own data. It's regression to the mean. Why is that? Because some people who were high cost last year are high cost because of events that have occurred that are not going to reoccur. And those events may either be related to health status, interventions, accidents, many other types of things. So we need to identify who those people are. I apologize for the train. I can't really do anything about that. So our task was to identify who are these people right here, okay, but back here, because we don't want to wait until the end of the year to find out who those people are. We want to find them at the beginning. So that's what we call the predictive model for persistent high needs. And it took us a while to get there. We knew what the issue was. It took us a while. But we've been able to develop a model that has a positive predictive value of 66% in a Medicaid population and about 74% in a commercial population. Now, what that means is if we say that someone's going to be high need this year, will they be high need next year? And we're right 66% of the time with the Medicaid and 74% with the commercial. And that's in tests, not always. I would average it out. I usually say it's 68 to 70. Like to be a little conservative. And the difference there also demonstrates one thing. These were models that were built initially only using claims data. So those statistics were based only on claims data. Now, that just goes to show you that there's some missing data there, and that the missing data is more important, or is really creating some error in false positives in your Medicaid population. That's why you lose some of that accuracy. That's why it's important to continue to try and get that additional information. Well, as soon as we built these models, then our clients were asking us, where do these people come from? So they introduced these models into their environment, and there's a great story to tell you about that whole process, which involves how do you go and talk to somebody who has a continuing low-level need for care, who hasn't been serviced very well by the healthcare system. And that conversation is a very different conversation than going to someone who has just been discharged from a hospital and you want to help manage a process to prevent readmission. So that's the other thing. Once you start developing these models to respond to your customers' needs and the realities of the care environment, beginning to think about what it means to apply a model in this environment, it's very important to have a collaboration so that there can be a feedback and an improvement of the model and an understanding of what they're finding, and also help them develop their program and work to deliver better care. So there was a whole effort here in terms of really how do you dialogue and enter the dialogue. And there are a bunch of lessons which are subject of another webinar around that. But then they said, well, where do these people come from? So we started looking at what are the factors that put someone in the position where they are persistent high need, and that's the emerging high need model. And there you see some factors which I'm sure you're familiar with. So high number of chronic diseases, high number of ED visits, high number of prescriptions, high medical costs, not counting ED visits and prescriptions, high number of specialists, unresolved pain, behavioral health issues, a number of other issues that aren't on this map, all of which represent a fairly complex set of conditions that these individuals are trying to deal with and are not being served by the healthcare system. I'm going to skip over this. We're going to run out of time. We've got a potentially preventable. I was going to talk a little bit about the ER model, and we've got readmissions and in-hospital complication models, all using some of the same kind of ideas to really get at the complex drivers that go into the patient. And that's the ER model. We're going to go on past that. I just want to give you some vignettes of these individuals who were found to go just a little bit deeper into how this plays out when we look at people who are emerging high need. Okay, and just if you can, take a minute and look at some of these individuals. And what you're seeing is that these are individuals who have a multiple set of problems, which a cluster of conditions that are as much symptoms as they are diagnoses, which have a behavioral health component or a mental health component, and in some cases what may be a substance abuse component, also have a pain or distress component, okay? And I have to say that for certain of these groups, there's a gender issue as well. There is a use of low-value services or the non-effective use of low-value services, so there's a cluster. And when people say, well, tell me who this individual is, it's a cluster, it's a population. And you might say, well, you're showing me individuals. Yes, but there are many of these individuals who have chaotic relationships with the healthcare system. And I'm not pointing a finger here. Is it the healthcare system? Is it the individual? Don't know. I mean, that's something that we're working on trying to tease out. Can we attribute, where's the emphasis placed here? But we can tell you through other analytic tools when you apply this, if we reverse the lens and we start looking at the healthcare delivery system, we can certainly identify areas where you have clusters of providers who are doing much better with this group of patients than another group. So this is just an example of how you might look at or use, and this then, as you can understand, imagine making a phone call to one of these individuals who is, as we have heard in conversations with these individuals, here's what we hear, here's the quote, "I've learned to live with it," unquote. That's the quote. So imagine making that phone call and trying to engage with them to help them resolve it. And we have many stories now where you can resolve it. You can change the course of the trajectory of these individuals' healthcare and their health status. And it all comes from identifying them and then working with the providers who are trying to take on these very difficult issues. Okay, so running out of time. This always happens. I want to mention that what's great is also as we develop the science of predictive analytics, the science of engaging with patients and increasing the communication and feedback loops between caregivers, patients, and providers. I use caregivers really as a shorthand for informal care cluster around certain individuals. The technology and science and art of being able to help the provider and the patient bring all this together is really evolving. So this isn't a advertisement for WellFrame. In fact, we don't have a business relationship with WellFrame, but one of our customers does. And they have found this, and it could be other methods. I just use this as an example of where a mobile application combined with predictive analytics, combined with delivering other types of information that can come out of a robust analytics engine, that information helping drive workflow, helping drive the interaction between the care manager and the team has been so critical. We've got some really great stories, and I'm sorry I don't have time, but there's some great just stories about people's lives being turned around and really helped. I think all of this, and this is the end of the, and we'll get some time here for questions, all of this needs to be rolled up into learning system. For me, that's what this is all leading to, is learning systems that the system itself has a value and a goal to learn. This is the old IHI model, right? And the system can be accelerated towards that goal with predictive analytics that can feed this learning and this understanding, and you can begin to identify at all three levels, system, clinician, and person, what's going on and what do we need to do? What kind of intervention has a high probability of success? So I'm going to stop there and open it up to some questions.
Okay, thanks a lot, Herb. That was a lot of great information. Now we'll turn it over to the audience to ask some questions via the web platform or by phone. Wendy, could you let the audience know how to do this?
I sure can. Everyone, ladies and gentlemen, at this time we'll conduct a live question and answer session. To ask a question via the web presentation, please select the chat pod located in the lower left corner of your screen and then type and send your question that way. If you'd like to ask a question via the telephone, please press *1 on your telephone now and you'll be placed in the queue in the order received. And if your question has been answered or you wish to remove yourself from the queue, please press *1 again. And I'll announce each caller prior to bringing you into the conference. Please remember that if you have your phone on mute, that you take it off mute when you're selected to ask your question. So again, to ask a question via the web presentation, you can select the chat pod located in the lower left corner of your screen and then type and send your question that way. And we're ready to begin, Joe.
Great. So while you're queuing up any phone questions, I'll start with written ones. Sure. Do you have a way to identify which members forego medication, and how does this affect their health status and cost to a plan?
That's a really good question, and I think is related to this issue of adherence. And so when we say forego medication, and let me repeat that to make sure I got it right. Can we identify people who forego medication, and what is the impact on cost and outcomes? Was that the question?
Yes.
Yeah. So we do. We have the methods which are also available to many of you. There are several well-known structured methods for identifying adherence, and that can be adherence to, in general, or it can be adherence to specific medications related to specific diseases. And what we've spent a fair amount of time is looking at whether or not adherence across the spectrum of conditions is, because our work is not only about people with multimorbid conditions. Okay, we look at all the populations, but a lot of our emphasis is in that area. People have 2 or 3 or more conditions. And so in that context, when you're talking about adherence, looking at adherence to one medication may not be the whole picture. And honestly, well, it isn't. I was going to say, adherence to your Crestor, not to single that out, may or may not be important. It may be a flag for other things. But we try and look at it across the board. And we are, very interesting you ask that. One of our customers asked us to take those metrics and begin to answer the questions that you asked. So we have used adherence in our models as an explanatory or an independent variable. We're now being asked to look at it as a dependent or an outcome variable as part of a pathway analysis. So your question, what predicts it and what's the outcome? So my answer is, I don't have the answer to that right now. But we are looking at it. You put your finger on something that a number of people are very concerned about. Why? Because we think that it's going to make a difference. And secondly, whether it's direct or indirect, because again, it could be a flag, right? But also, we think that we can do something about it. And I think we're right about that. I think we can do something about it. So thank you for that question. I'm sorry I don't have the answer right now. We're working on it. I expect to have the answer. I can't tell you when, but it is on our priority list. Thank you.
Okay, great. I know a couple of people asked if you'll receive a copy of the slides, and yes, we plan to email them out to all the attendees after the meeting. Another question that came in. What would you say are the biggest problems you're facing in the field of predictive healthcare analytics at the moment?
I would say, and I was, I don't know, when a speaker says, that's a really good question, they did some research on that, and they found out that usually they say that so that they can gather time in their brain to respond. But that is a really good question. So obviously, data that enriches our understanding is critical. But the other piece is that is starting to be less and less of a factor. It really is. And so then it becomes, let me tell you what's not a problem. The techniques are there. Not only are the techniques there to do some of the straight out what is related to what, but beginning to identify what I think has been a real conundrum is identify patterns, okay? Do the longitudinal work to really not say that this person just has two multimorbid conditions, but tell me about the trajectory. What was the trajectory for all that, and what's the trajectory going forward? Now let's use that information to categorize this patient, and then bring in all the rest of it. So trajectories and patterns, those technologies are coming forward. I think it's figuring out, and this it may sound a little self-serving because this is what I love to do, but it's figuring out what is the priority for something that will make an impact, have an ROI for the customer, because it takes a lot. When somebody, look, producing a number, a risk is good, okay, but then you've got to organize. You have to have people who are interacting with other people for all of this to make a difference, or changing systems of care. Changing systems of care, as you all know, is not easy and it's not inexpensive. So you really, it's the second piece, and really identifying what's your priority and how do you structure the question. None of this is going to have what it has to have, which is clinical validity, if you're just going to throw things into a hopper and let your machine learning push out the response. You have to start with the right question. You have to start with the right hypothesis, the right collection of information and categorization of it, and then you have to guide your work so that it has clinical validity and program feasibility and program importance. That kind of the art of predictive analytics is, I think, always the ongoing challenge. And then the piece that I brought up before, where we'd like to go, because I'd like to see us put this power in the hands of all of us, that we as consumers, we should be the people that use these engines. But in order to do that, it's a two-way street. So we're going to have to contribute our readiness for change, our ability and our experience for change, and our value structure. All of that has to come in for these models to really reach their true capabilities.
Okay, I think we might have time for one more question. How does a small group or individual physician practice use the analytics methods outlined here? It would appear that the trend toward larger practices or being bought by health systems would be essential.
So in terms of a small group, I think then it becomes, what is it we're talking about and what are you responsible for? So I would think that if you're in a value-based payment system where you are at some risk, you're going to want something that's going to help you identify the people that place you at greatest risk. Whatever is your scope of risk, that's what you're going to be looking for. So I might suggest that many of these systems will place you at risk, sometimes for total cost of care, sometimes not, but they may place you at risk for emergency room use and for ambulatory care sensitive condition admissions. You may be placed at risk partially for readmission rates. You may also be placed at risk for adherence, and you may be placed at risk for the use of your patients of low-value services. And it's a huge conversation about whether or not you should be, how much your scope of control is on those things, but being able to predict some of those factors and who's most likely to be at risk for those things. The other thing is, I'm sorry, I just missed a very important thing. That is the issue of your quality measures as well. So whether it's MACRA or something else that you're involved in where there are quality measures that are in play, that identifying who is going to need more attention so that your quality measures look better is an area that we're asked to spend a lot of time looking at.
Okay. I think we've run out of time. So I wanted to thank Herb for your discussion of predictive modeling, and I'd also like to thank the audience for your participation and attention as well. I hope you enjoy the rest of your day.
Thank you.
Thank you, everybody. I'd like to bring your attention to the survey that I just displayed on your screen. If you would take a few moments to complete and submit the survey to us, we would really appreciate your feedback. This concludes today's webinar, and we thank you all again for attending today.